So we'll talk today about the biological treatment of the teeth. And it will be a story about the treatment of the deep caries, reversible and irreversible pulpitis. But we'll not talk about the root canal treatment because in many cases, and it was surprising some times ago, it was when I realized that, it was really surprising for me that we do not have to treat all the teeth with the pulp inflammation, with the pulpitis. We do not have to all of them to do the endodontic treatment. And this is the true story. There was the story, the animated story, and this is the true story of my patients. And I think that it's the very common story because of a lot of patients are coming to us, to our offices, and they are saying, "Oh, doctor, I have a pain in my tooth." And this was the story of this patient. He came to my office and said, "Oh, doctor, I feel the pain from 2 weeks or even more, but I cannot stand it. No, I cannot stand it. But after 2 weeks, maybe when if he took appointment 2 weeks ago, it could be a little better. But now, as you see, it seems little bit horrible." But of course, when we see something like that, in most cases, or maybe in every cases, I'm doing the X-ray, and this is the result of my X-ray. And as you see here, you can see, and I think that year ago or 2 years ago, when I saw something like this, the caries, as you see, the lesion is very deep, the caries is deep. Normally, I'm saying to my assistant, "Monica, please prepare the set for the endodontic treatment. Please prepare the microscope." But it was 1 year ago, and now I'm thinking a little bit different. And why I'm thinking a little bit different? You have to remember that even if you are a specialist in endodontic treatment, I am a specialist in endodontic treatment. I'm using the microscope for the treatment from 15 years, so a lot of time. I've got the experience. I'm doing the lectures about the endodontic treatment, but I'm still prefer to avoid this, to avoid if I can. Why? Because we have to remember that even if you will do the perfect, absolutely perfect endodontic treatment, there is still risk that there will be something wrong, and something will go not the way you are thinking or you want it to go. And another thing is that if the tooth is invital, it's not so the tooth is not so tough, so this tooth cannot stand the forces as big as a vital tooth. If we look a little bit closer for this tooth is 6, the molar, we can see that the root canals are curved here. This is not the very big curvature, but it is. But if we look for the palatal root, look for this here on the end. So it could be we could have some problems to do the proper endodontic treatment in this case. On many of my lectures, endodontic lectures, I'm showing this this form. This form was created by the American Association of Endodontics, and this is the case difficulty assessment form. And I'm always showing it on my lectures because I think that not all of us are thinking how difficult could be endodontic treatment, and there is a lot, really, as you see, a lot of things that can affect the difficulty of our treatment. For example, medical history, possibility of anesthesia, or if the tooth was treated first time, or if it's retreatment or something like that. If there is what is the morphology? You saw this slide before. The morphology of that molar is not so easy. Of course, we can treat it. We can do the endodontic treatment, and possibly everything will be good. But still, it will be in vital tools. It will not be the vital one. So I will not talk much about. I will talk not more about the endodontics. I want you to show this slice of the tooth. With here, if you look here, we've got the carious, but this is the medium carious, so it's quite far from the pulp. It's safe. And my question is, in this case, if in the case of the medium carious, are you using aligners for the composite filling or not? I'm not. I'm not using from years. Why? Because as I remember now, I'm almost not using the aligners, but I remember from past years that a lot of liners that producers are preparing for us, they've got the resin inside. Not all of them, of course, but a lot of them, they've got the resin. So if you are putting the resin as a liner, just to protect the pulp from the resin, from the composite material, it's something illogical for me. So I'm not using in the medium carious. I know that the pulp can stand these chemical problems that the monomers could do for the pulp. So in the case of the medium carious, I'm not thinking about any liner because I do not have to. But what in the case of the deep carious? This is a different situation. This is a different situation because from years when I had the really deep carious, I was trying to clean it as possible, to clean all the edges of my preparation, to clean it, and I was leaving a little bit of carious. I was leaving the not hard enough dentin, but this dentin was some kind of so when I was using the probe to check the dentin, so on the wall of the tooth, on the wall of the cavities that was neighboring with the pulp, I was leaving the carious, the carious infected dentin, but this dentin wasn't really soft, but it was possible. I was able to scratch it with the probe, and I was using the glasionomer cements, and they worked very well, very well. Here you can see this is the glasionomer cement after the half year. We can see some cracks here, but it still works. There is still no leakage, so it's quite good, and it was working for me years. But I was able to put the glasionomer cement only if I have no signs of the pulpitis, irreversible pulpitis. It was the first and the main point. And the second, I was able to put it. I wasn't able to put the glasionomer cement for the exposed pulp. So there was a lot of still there are a lot of indication for glasionomer cement, but it's not good. It's not the perfect material for all of the cases. And in such case, this is quite similar like the first one. If you look for this, there is the big caries. There are the signs. There are the signs of the pulpitis, but the pain is from 1 or 2 days, and the patient feels the pain when he is eating or drinking something. And in this case, should we perform root canal treatment, or maybe we can do the conservative treatment? This is the question. And normally when I see such X-ray, I'm explaining to the patients that I don't know if I will have to do the full endodontic treatment or not. But from some time, we've got some things that we can do, because we've got some materials that I'm really happy that I started to use it, because we've got the Biodentine. It's the bioactive cement based on the tricalcium silica, and I have to say that Biodentine has a lot of advantages, and I will try to show them to you now. So, but we'll start from the indication. And for the first, I want to, on the beginning, I want to say that I'm not treating the children. I don't like to treat the children. So I will talk about the cases for the adults normally, because if I do not have to treat the children, I'm not doing it. So I will talk about the main indication mainly for the not for the primary teeth. So the first indication for the Biodentine is the medium caries, like here. So here we've got the medium, maybe quite big, but still medium caries. Is quite far from the pulp. And just few minutes before, I was talking about that I'm not using liners. Yes, and still I'm not using them. But in some cases, it's not if it's the medium caries, and it's quite far from if it's the medium caries, and I'm quite far from the pulp. I'm choosing the Biodentine, but this Biodentine works as a bulk material. I think that you heard about this. This is the layer of the Biodentine. I think that you already heard about the method of the filling to fill the posterior teeth, called bulk and body. And in the original bulk and body, in the original, I can say bulk and body method, we are filling the, I can say, the dentin part. We are filling with the bulk fill composite materials, but it's still the composite. So, but we are filling this part like here with the bulk composite in white one portion, and then the last 2 millimeters we are filling with the normal standard composite. But still, we've got the resin, a lot of resin here. We've got a lot of monomers here. And if we want to treat more biological, we can change the bulk fill composite material to the Biodentine, to the bioactive cement. So we are putting the bioactive cement so we are filling the dentin part, and then just the last 2 millimeters we are filling with the normal composite. I will switch now to my camera. I will switch to my camera, and you will see because I prepared, this is the Biodentine, and here I've got the model and the teeth, and this is this is the biodentine that is already set, and this is exactly what I'm doing, how I'm filling with the biodentine in the case of the bulk fill, bulk and body method. So I'm taking the probe. I can take the probe with like with the signs of with the measurement, or I can take like here. I can have the probe with the endodontic stopper, and I'm checking the height of the dentin layer, and I can fill that the rest with the composite, and I can do the composite like here. You can see on the neighbor tooth we've got the this is the tooth that is filled with the bulk and body method. So this is it. So I will switch on again for my presentation. And we are going back to the indication. So as I already said, the one of the indication is the bulk and body method to fill the cavity in medium caries. Another in the much deeper, in the deep caries, we can fill it with the biodentine, even in the full one, and it will be indirect pulp capping method. So this is not, so we can use it in when we've got, for example, reversible or even irreversible pulpitis. Another indication, if we've got exposed pulp, we can use the biodentine as a long temporary filling material. We can keep it even without the composite here. We can keep it for the max 6 months, and we can heal at the time. We can heal the pulp, but we can use the pulp in vital tooth. So, for example, when we finish the root canal treatment, we can fill all the chamber and the most of the dentin. So we are replacing the dentin with the biodentine. So the Septodont is calling the biodentine named the substitute of the dentin, and I have to say that I agree with that. And in other cases, so for example, if we got the perforation like here on this, we can use and we can fill it with the biodentine. If we've got very wide canals and open physiological foramen, this is too wide, we can use biodentine here in this case too. So as you see, this is really universal. This is really universal material. Okay, let's go further with our presentation. Indication. And so I think that most of you already know that, and if not, if you not noticed that before, the biodentine is, I can say that very similar to MTA, and I think that most of you knows MTA very well. But I'm saying that biodentine is some kind of improved MTA. The main ingredients, it's in both of these bioactive cements, it's tricalcium silicate, but in biodentine there is much more. And why I think that biodentine is better in most cases than MTA, because of many reasons. The first reason is that biodentine is much easier in handling. So it's the consistency of the material is much it's much easier to work with the biodentine. Another point is that the solubility of the biodentin is less than is lower than solubility of the MTA. And why it's like this? Because in to mix and to prepare biodentin, we are using just for the one portion, we are using just 5 drops of the water and nothing else. Just 5, not the water, the special liquid there is, which is in the sets with biodentin, and we are just putting 5 drops. So in the whole the mixture, there is very small amount of water. So the solubility of the biodentin is less, and in face of this, the biodentin is has a very good compressive strength. So the strength for the compressing is really big. So after 1 hour, we've got 100 megapascals of the compressing strength. After 24 hours, we've got 200. And after 1 month, because you have to know that the full crystallization, because we are not talking about the polymerization of the biodentin, we are talking about the crystallization. After the 1 month, the crystallization is stopped because it's full, and the compressive strength of the biodentin is about 300 megapascals, and it's 300. It's the same like a natural dentin, because the natural dentin compressive strength it's 290 and 295, something like that. So it's really substitute of the dentin. MTA is not so it's not so tough. And others that we know that from our practice, and we know that from the clinical trials, that in case of using the biodentin, the risk of the discoloration of the tooth is much lower than the risk if you are using MTA. And this is, I think, that it could be important. It not could be. It is important for our patients and for us too. So the biodentin is really we've got advantages according to MTA. And another advantage is the setting time, and this is really important for us as a dentist, as the practitioner, because the biodentin is starting to set after the 6 minutes after mixing. So you got the 6 minutes to manipulate. So after the 6 minutes, the crystallization is starting. So it's starting to harden, and after 10 to 12 minutes, it's hard enough, and we can go further. And the working time and the first setting time of the MTA is 70 minutes, and we can say that MTA is set after 170 minutes, 170, even 5, I remember, 175 minutes. This is the time when we can go further and make another step. So the time is really, in case of biodentin, is much slower, lower. So this has a very practical. This is very practical for us, and there is the one thing that in which the MTA is better. It's the biodentin is less visible in the X-ray, but it's if we know that there is a biodentin, you will see some X-ray after the putting of the biodentin, so you will see that you will be able to see them. But the contrast in the X-rays of biodentin is lower than for the MTA. So for the diagnostic reasons, MTA is little better. But it's important. Biodentin it's cheaper. So this is another I think the big advantage for us with the Biodentine. And so you will see some of my cases, on the cases when you can you can use the Biodentine. For example, this patient came to my office. There was here, it was the really huge the composite filling, and there was the big leakage in this filling. So there was the secondary carious here, and this carious was very close to the pulp. So it was really perfect. It was a really perfect indication, a perfect case for the Biodentine, because the patient has no signs of the pulpitis, and there was no problem of the occlusion or with the Biodentine, because all the occlusal forces are working here, not here. So the perfect situation you can live, we can live for the 6 months this Biodentine without any problem. Another case, it was one of my first cases with the Biodentines. It was sometimes, it was, I think that more than 2 years, maybe about the 2 years ago. These patients came to me in this condition, like you see here. We've got the very big perforation, and the story behind this was that these patients came to her and to her general dentist, and there was the inflammation, and the dentist start to look for the root canals, and there was a big enamel stone here in the coronal part, and the dentist was looking for the canals and cannot find them, and did something like that. When I saw that, I said to my patient that I'm sorry, but it's too big, and the perforation is too big, and there is no chance for this. But these patients start to beg me, doctor, please try. It will be my responsibility. So please try to do something. So I decided to treat it with bioactive cement. So I filled it with the bioactive cement here, and it still works. I've still got the contact with this patient, and it still works. So it was the perfect case for the Biodentine. And another case, quite similar but a little bit different. This was the patient came to my office. She came to me after the endodontic treatment. The root canals were already filled, and were filled without any voids, and it was, in my opinion, it was made with a good it was a good endodontic treatment. But the patient still feels something, some pain, and she was asking her dentist and said, oh, I feel some pain. No, it's impossible, everything is okay. I feel some pain. No, it's impossible, everything is okay. So she came to my office, and I opened this tooth, and I saw this big perforation. And it was some time ago, and it still works. It's another perfect case for the Biodentine. And this case, you know, because it's the case from the beginning. We got the big caries. You will see how I did that. It still works. You know these patients. So first, I'm always when I'm working with the deep caries, I'm always using the rubber dam. This is very important if you want to treat pulpitis, if we want to treat and to have the good results with the treatment of the deep cavities. We have to use rubber dam. I know that a lot of dentists are not using, but I'm always convincing them to start doing that. So I put it. So we got the rubber dam. I started to clean. And what is important when we are cleaning the tooth, you have to clean as much dentin as you can. But in this case, here I hope that you are able to see the dentin here. This dentin is darker, but I checked it with the probe here and here and here, and there was no scratches with the probe, so it was hard enough to leave that. But I left the soft dentin here. We can see here we are almost in the pulp. So in this case, we can just put the biodentine for the whole, wait 12 minutes to finish the crystallization of the biodentine, and remove the and remove wedges and everything, and we've got the end. As I said before, we can wait. We can, after 12 minutes, we can remove the layer of this. I will talk about it later, about the biodentine, and put the layer, the 2 millimeters layer of the composite. But normally, I prefer to wait some days. I prefer to wait, and then when the biodentine will be really hard, I'm removing this layer, and then I'm putting the composite material. And in this case, I decided to do the full, of course, the temporary, but the full filling with the biodentine. And what is the common problem? I'm always trying to avoid that, but we have almost the contact point here. Here we've got some contact point, but not here. So now this is quite old case, but now I'm doing a little bit different. If I can, I will erase this. If I can, I prefer first to close this wall, to rebuild this wall with the composite. So I prefer to make a box or the first class cavity, and then to fill with the biodentine. In my opinion, it's much better to do that way. But I mentioned before about the irreversible pulpitis, and few months ago I saw this trial. I saw this trial made in 3 years ago, so it's not so it's not so new, because it's 3 years, but it was quite new for me, and I saw that, and it was some, for me, like a bang in my head, because I saw that it was really how to say it. I was really surprised that it's possible, and when I saw this trial, I said, oh yes, this is something perfect. I have to try it. And from this time, I'm trying to do that. As you see, we've got the 22-year-old man with diagnosis of irreversible pulpitis, and we've got the D. It's the 26 months follow-up, and this tooth is still vital. So it was really, for me, it was something really big, and I started to think about that, and I was really happy that I can try that, and I do not have to treat a lot of teeth endodontically, even if we've got the irreversible pulpitis. But you have to be aware, and this is really important, that when you want to treat with the biodentine, with the bioactive cements, if you want to treat the teeth, if you want to try, first you have to really explain deeply everything to your patients. Why? Because patients are coming to your office. Most of them are afraid, like these patients from the animated movie on the beginning, and most of these patients are afraid of the pain and they are afraid of the dentist, and so are waiting so long to come to our dental offices. And they are coming to us, and they want to go back to their homes without any pain. So they think that when they will leave our office, they will feel no pain. But in the case of the irreversible pulpitis, we have to aware our patients that there is the risk that they will feel the pain. And normally, from my experience, the patients still feel quite high pain, quite big pain for 2 or 3 days, and then the pain is going to be lower and lower. So you have to be aware, and you have to remember that you have to explain everything to your patient, and you have to ask them, and you have to be sure that they know what you are talking about. What is good for us and what working for us, that in case if you are doing the proper procedure, if you are doing the procedure, and about the procedure I will talk a little bit later on the next slides, and if you are following the full procedure, we've got the 90% chance of the success. So 9 per 10 cases will be successful. So it's really big. So imagine that to our office there are coming the patient with the irreversible pulpitis, and normally in the classic dentistry we are taking the set of the endodont for the endodontic treatment, and we are doing the endodontic treatment, and the patient has a non-vital tooth. It still has, but it's non-vital, and it's not 100% good tooth if it's not vital. So you can see that I hope that you will have opportunity to try that. If we will use the Biodentine, and if we will follow the procedure, we have the 90% chance of the success. So this is very big chance, I can say. So here you will see the Biodentine step by step in irreversible pulpitis, how we are doing. So we've got the patient, we made interview. Of course, this is important to make RVG and to make X-ray and to check how this tooth looks like. This is important to check if there is any reaction of the pulp, because if there is no reaction and nothing happens, maybe there is necrosis of the pulp. So we have to differentiate that, but we'll see it after drilling. So first we are doing anesthesia. It will be the best if we will do the anesthesia with articaine. We are doing anesthesia, we are putting the rubber down, and then we are doing the preparation, and we are exposing the pulp. And when you will see the blood, this means if you will see the blood here in exposed dentin, you will know that it's not. You can be sure that it's not the necrosis on the pulp, and this really could be pulpitis. I can say that it will be pulpitis. And we are doing the disinfection, few minutes of disinfection with the hypochlorite or chlorhexidine. I prefer hypochlorite because the hypochlorite, in my opinion, it stops bleeding faster than chlorhexidine. And we are waiting 5 minutes, and we are looking for the clock. And if we've got the hemostasis during the 5 minutes and there is no bleeding, from the pulp, we can go further. If in the case where there is the bleeding, we are doing the partial pulpotomy. So we are removing with the clean burrs and with the water one in the head switch on in the headpiece, and we are removing the part of the pulp. We are disinfecting it with the hypochlorite again. We are waiting 5 minutes, and if there is the hemostasis, we can go further. If not, we are going deeper. We can remove the whole pulp from the pulp chamber, and if we reach in this level, this is the last level before the endodontic treatment. If we reach the hemostasis, we can go further. So we are filling the cavity with the biodentine. If it's possible, if you've got time and possibility, it's good, as I said before, to rebuild this wall with the composite material, because it will be it will stand more forces, much more forces. And then we are going, if everything is okay, we are waiting 2 weeks, at least 2 weeks. Why we have to work 2 weeks? Because after, as I said before, the crystallization is still going. The material seems to be hard after, or quite hard after 12 minutes, when we can start to do something. But it seems quite hard, but it's still, the crystallization is still going. So it's, if you can wait, if you can wait 2 weeks, at least 2 weeks, it is good to wait. And we are removing the part, the 2 millimeters of the biodentine after the 2 weeks, and we are doing the full bonding procedure. And there is the question how this bonding procedure should looks like. And it's not so easy to say, because I read a lot of trials about the bonding to the biodentine, but I'm doing like that. So I'm waiting 2 weeks. I'm etching biodentine, both biodentine like enamel, and I'm using normally, because on my every practice I'm using the newest universal bonding system. So these are the self-etch system, the universal ones, so the last generation, I can say. But I prefer to use to etch with the phosphoric acids, even if I'm using the universal self-etching bonding system. I found some nice trials, but it was they are made in vitro, not in vivo, so we are not 100% sure that it will be the same in the mouse. And it was about the shear bond strength to the biodentine, and from these trials there was the conclusion that it's better if you are using the etchant or the universal system. It's better to etch for the longer time. So if you are using the etchant, it's good to etch biodentine more than half minute. So in these trials, there was 6, as I remember, it was not 6, 3 minutes. So yes, it was it was 240 minutes, not minutes, seconds, minutes. Oh, I'm talking, sorry, 2 minutes and 40 seconds. Oh, yes. So it was easy. So we have to, if you'll wait little more with the phosphoric acid, we will have the better adhesion to the, we will have the better adhesion to the biodentine. And after that, the last part, So on the last 2 millimeters, we are putting the layer of the composites that you are working on every day. But it's not the end of the treatment, because we have to make appointments to check if everything is okay, to make an X-ray, to check the response of the pulp for the temperature, for example. So normally I'm making appointment after the 3 months, and then after half year, and if everything is okay, I'm doing the next appointment to check after 1 year. And this is the Biodentine step-by-step procedure in irreversible pulpitis. To summarize that, one of the most important things that you have to remember in this procedure, to follow this and to have more than 90% of the success rate, is this: you have to reach during maximum 5 minutes, you have to reach the hemostasis. If you are not able to reach the hemostasis during the 5 minutes, remember of course about the disinfection. If you are not able to reach it, you have to try to make the partial pulpotomy or full pulpotomy. But if it still doesn't work, you have to do the standard endodontic treatment and the root canal treatment. This is I think the main thing, the most important things that you have to remember. And this will be almost at the end, it will be a clinical case that I really like, because this is the deep carious, and this is the same situation like the first, or like on the first. This patient is the 33-year-old woman. She was waiting more than 1 month to came to my office because she was afraid, and she is a businesswoman, and she said that I was afraid of the treatment, and the second, I have no time for the treatment. And after more than more than 1 month, uh, more than 1 month of the pain, she decided, oh, I can't stand it anymore, so I have to go to the office, and she came to me, and of course I made an X-ray, and I saw something like that, and I said, oh, we got the problem. Why we've got the problem? Look for the level when we've got the caries. It's quite high. Even if I will be able to treat the tooth, and even if I will be successful with the biologic treatment of these tooth, I'll still will have the problem. I still will have the problem to rebuild these tooth with the prosthetic, because of the biological width. We are very close. We are really here. We are very close to the bone. So here I think that it's less than 1 millimeter to the bone, so it's not enough. But the patients I was talking to, it took me quite long time to explain everything to her, and she said, doctor, if there is any possibility that you will not have to do the root canal treatment in these tools, I want to try. And I said, okay, but I will not say if it will work or not. And I was really surprised, because it was half year ago, I think, and this is the view of these tools, and it still works. As you see, it looks quite good here, and it still works. I'm still waiting, and after half year, we'll have to decide what to do with that tooth. But I think that maybe if the patient will not decide for the prosthetic treatment of this tooth for the crown, maybe I will rebuild the composite, but just here, I will not go deep. I will not go as deeply here. I will just fill this part with the composite. I don't know. I'm not sure. We'll see. Maybe when we'll see on the other lecture or webinar, I will have the further information about this story about this patient. Thank you very much for this part for the webinar. So I'm waiting. Very soon we'll start the question and answers. Here you can see my email address. It's Michal Ganowicz, gmail.com, and you can, if you have any questions about the Biodentine or other dental questions, please feel free to write to me. And now I will switch off my presentation and we'll have the question and answer session.
Thank you very much, Dr. Ganowicz. Thank you. So we are close from the end of your lecture, but yes, some questions. A question: can we just fill the entire cavity with Biodentine, eliminating usage of composite?
We can do it, but only temporary, because we can do it just for the long. The Biodentine could be the filling as a long time temporary. So after the 6 months, it could shear too much. So you will lose after the 6 months if the Biodentine is on the occlusal side. You will lose the outer layer of the Biodentine, so you have to replace it. Because if you will wait too long time, there will be no leakage, because there is no problem. But you can, inside the cavity, you can expose the dentin, and if you expose the dentin, patient could feel some hypersensitivity. But it will be after half year, I can say. Maybe I think that in the very small cavity, for example, on the buccal side of the molars, where you've got the deep but very small cavity, I think that it could be possible to leave the Biodentine. But normally, as I said, you can treat the Biodentine as a long temporary filling material, and it's always better after at least 2 weeks, and it will be good if you will wait 1 month just to put the layer of the composite on it.
Thank you. Another one, do you prescribe a patient with any meds, analgesic or antibiotics for those that you may anticipate post-operative pain?
Sometimes just something for pain, but it's but there are the paracetamol or ibuprofen or something like that. So ibuprofen. So it's nothing. It's nothing big. Sometimes when the patient is suffers really. So I'm using some more powerful pain killers, but I'm not prescribing antibiotics. I'm leaving antibiotics for the end, because of the problem of the bacteria, and my opinion is that the dentist and the people on the world, we are using too much the antibiotics. So if it's possible to avoid it, I'm avoiding it, and I'm using. In the dentistry, I'm using the antibiotics only if the patient has the necrosis or some very big inflammation in the apex area. Not if there is the irreversible or reversible pulpitis.
Thank you. Is Biodentine applicable for primary teeth?
Yes, of course. Yes, of course. I'm not doing that because I'm not. I really don't like to treat the children. But yes, in my opinion, it's a very good. In the opinion of my colleagues that are doing a lot of treatment of the children, this is the perfect perfect material for the children and for the primary tooth.
Thank you. If there is no hemostasis after partial pulpotomy, do you go for complete pulpotomy and wait another 5 minutes for hemostasis?
Exactly. We are doing the full pulpotomy and we are waiting another 5 minutes. If we'll gain the hemostasis, it's perfect. We are doing the biodentine. The problem with the full pulpotomy is one that will not be able to check the vitality of the tooth with the temperature because there is the very big chance that there will be no reaction for the temperature, for example, and the only possibility to check if you are successful or not, it's the interview with the patient. If there is no pain, there is a chance, but the chance, and we have to, if you are doing the full pulpotomy, the only chance to be sure that that we are successful is to do the X-rays during even 4 years. So every half year we should do the appointment, make X-ray, check if there are any signs of chronic inflammation in the apex area, and every half year. And after 4 years, because why 4 years? Because the 4 years we can say about the success of the endodontic treatment, we can say after the 4 years when there is no signs of the chronic or any other inflammation. So it's exactly the same. When we are doing the full pulpotomy, we have to check X-rays every half year, and after 4 years we can say when there is no symptoms, the pain, and no chronic symptoms, the inflammation, the symptoms in the X-ray, and this is the only possibility to be sure that we are successful.
Lots of questions around the hemostasis. So what method do you use to achieve hemostasis in pulpotomy?
The easiest method is to use the hypochlorite as I'm using, because it's I don't know how to say it in English, but it kills it stops bleeding because it's made the layer of the blood, I can say, so it's closing. If I've had a problem, there is one method that I'm using from years in the endodontics treatment and in the canals, and I'm using the same with the hemostasis in the pulp. You can rinse the pulp with hot saline solution. The normal root saline solution. I'm just taking the syringe, filling with the saline solution, putting to the hot water for some time, and I'm rinsing the cavity with the hot saline solution. But it is extra, and it's not instead of the hypochlorite.
For premolar and anterior, sometimes the pulp floor can be difficult to estimate. How deep would you go for pulpotomy?
I think that it's normally there is the rule when you are opening the root canals. There is the rule of the 7 millimeters, but it's normally in premolars. But it could be the same in the premolar with the one root, with the one canal, for example, the lower premolars, and it's quite the same in the front teeth. And the rule it's the 7 millimeter rule. So if you are opening the cavity and you are going deep just to 7 millimeters. If you will extend that, there is the big risk that you will do the perforation. This is very useful in the case of the enamel stones. Even if you are working with the microscope, you are not you have the problem to see the root canals and the entrance to the root canals. So I think that the 7 millimeter rule is the best. So if you are trying to do hemostasis in the front in the premolars, you are going deep, and if you are reaching 7 millimeters, you have to think maybe it's time. Not maybe. I think that it's time to stop. If you are not reaching the hemostasis on the 7 millimeters, you have to think if to go further or not.
If patients don't have any complaint after 6 months, can we just assume that we are on the edge of success and we don't have to take X-ray?
I always prefer to take an X-ray because the amount of the X-ray is now in the nowadays RVG is so small that it's not dangerous for our patients. And I always want to check, but after half months, we are not sure if you will able to see the changes in the apex area. But after 6 months, you have to check, of course, if it's not the full pulpotomy, but even if it is, you can to try that. It's good to check the reaction for the temperature, for the cold temperature. I think that this is the best. If the patient is if the reaction of the pulp is good, so the patient feels something, but immediately after removing this the cold cotton or micrographs that you are using for that, if the pain is going out, it's good, I think. So we are sure that we are successful.
Can we bond the Emacs only on Biodentine?
Good question. Yes, we can. Yes, we can. You have to remember, I've never seen, I don't know if there are any trials about the connection, about the strange bonds about the Emacs and the Biodentine. But we've got the trials, but we have to remember that we are not gluing directly Emacs with the Biodentine, but we are using the bonding system and some cement. And normally we are for the Emacs we are using the composite cement, and then we are putting the Emacs. So my answer is yes, you can.
Does Biodentine act just as a physical barrier?
Yes, yes. I don't know if we can say that just physical barrier, but it is. We have to remember that I missed that information that Biodentine is really, I can say, is friendly for our cells and for the pulp. So the Biodentine has anti-inflammatory properties. So because the pH is very high and it's alkalic, and it stops the Biodentine stops the inflammation, the inflammation response of our body, and it's really safe for and it's biological safe for our body. So the Biodentine is not cytotoxic.
Can we use Biodentine to treat cracked tooth syndrome?
If, in my opinion, yes, we can. Yes, we can. But of course, if you are doing that, just put the Biodentine just in the as a part of the dentin, you have to remember that in any case when you are treating the crack tooth symptom, you have to really be aware about the occlusion and about the occlusion of these tools. So you have to check if there are any uneven contacts, if this tooth is not loaded too much, because sometimes the teeth are cracking because they are the first contacts in maximal intercuspidation position. So you have to be really aware about the occlusion with the tooth and about the whole occlusion. But yes, you can use it.
Thank you. And it will be the last question. How much would you charge for a class 2 filling restored with Biodentine and a composite?
For the tooth filling, normally I will not talk about the prices, because we are the prices in Poland, and I'm working in the dental office with the high level of the equipment, and we are quite expensive in the Polish level, I can say. But normally for the first visit, I'm taking like for the filling, just normal composite filling. So normally I'm taking the first time, this is the Biodentine treatment. The patient is paying for the exactly the same like for the normal filling, and after the time he is paying again the same price for the last filling. Why I'm doing that? Because we have to remember that at the end the price of the full treatment will be just 2 fillings. And if we will decide, if I will be successful, it will be just 2 fillings. And if not, if I will not decide to treat the tooth biologically, I have to do the endodontic treatment in many cases. And endodontic treatment is much more expensive, and there is much bigger risk of some problems. So still, if I'm taking the 2 times for the filling, the patient is still paying much less than if we will have to do the endodontic treatment. But of course, I'm explaining it to my patients. I'm not saying, okay, you are paying this and this, and patient is coming after 6 months, and I'm saying, okay, you have to pay another time, and patient is angry because he already paid for that. No, I'm always explaining why I'm taking this part, the price for the first visit, and the same price for the next one.
Thank you very much, Dr. Ganowicz. I think that we come to the end. Thank you all for attending. We were very happy to see you during this lecture. Thank you all, and
Thank you very
bye.
much. Bye.